I chose to do bipolar disorders. Okay, so spectrum disorders. Bipolar 1 disorder. In order to be classified as having bipolar 1 disorder, you have to have at least one episode of mania alternating with major depressive episode. And psychosis may be present during a manic episode. Whereas with bipolar 2, it's one or more hypomanic episode alternating with a major depressive. So they're not experiencing the full manic episode that those with bipolar 1 do. So very similar, just bipolar 2 is not as severe. The etiology, so genetics, immediate family members have a 7 times higher chance to get the disease if like an immediate family member has it. So 2 parents having the disease gives their child a 50% chance to also have it. Siblings have a 10% chance to have it. So if I have the disease, my sister's 10% more likely to also have the disease. Then we've got the physiological factors like the neurobiological factors that include the norepinephrine, dopamine, glutamate, serotonin, and GABA that all have a disruption between their circuits. So that causes dopamine, the disruption in the dopamine causes either the depression or the mania. So low levels indicate depression and high levels indicate mania. Serotonin has the same concept. Too low causes depression, which often leads to anger, and too high causes mania. Neuroendocrine factors, the hypothalamic pituitary adrenal, so the HPA axis, is having abnormalities between the stress pathways, basically. So that leads to higher levels of cortisol, so which leads to the hormones. I mean, so basically they're saying this is a hormone-induced disease. Like, there is an actual reason this is happening. And then there's also the neuroanatomical parts, which MRI studies have recently shown that there is a minor deficit in gray matter in patients with bipolar disorder. And that's specifically in regions of the brain that have to do with your mood, which is why it affects your mood and it fluctuates from those high highs to those low lows so much. That there's also reduced volume in the hippocampus, the amygdala, and the striatal volume. This causes dysfunction in prefrontal cortex and the limbic system as well. Environmental, stress is not a cause of the disease. However, it has shown that stressful life events such as like divorce or losing a sibling or a loved one can trigger those mania and depressive episodes. And then sleep disruption. If we throw our circadian rhythm off and we aren't getting a full 6 to 8 hours of uninterrupted sleep each night, that's also going to be a factor into when we have our swings. So then there's cultural. So we just need to be aware of cultures indicating different diseases. So if all diseases in the mental field typically present or are very similar with their signs and symptoms. So we just need to keep in factor if they're an African American, then we should probably more likely induce them or look further into schizophrenia. Sorry. The pathophysiology. I found this on a website I've got quoted here. It is characterized by dysregulation in the dopamine and serotonin systems and by pathology in the brain systems involved in regulating emotion. So basically dopamine and serotonin, they're dysregulation is causing the dysregulation of our emotions. So there is a reason it's happening. 4.4% of the US suffers from bipolar disorder. 1/3 of the symptoms appear before 13, with the rest of the symptoms appearing before age 18. If you are diagnosed with cyclothymia as a child, it increases your chances of having bipolar 15 to 20%. Comorbidities, other comorbidities, if you've got an anxiety disorder or a mental disorder, or again, like I said, cyclothymia, it is very likely, not very likely, but it is common to also, that's a common underlying factor of bipolar disorder. It's also recently been linked that ADHD is commonly shared with people who also have bipolar disorder and substance use disorders. 25 to 50% of those diagnosed with bipolar disorder attempt suicide, and of those 15 to 20% are successful. So how to diagnose? The mood disorder questionnaire, although it is quite a bit older, it's still a good backbone for physicians that they like to fall back on. So I've got one here in front of me that, just for an idea, has there ever been a period of time when you were not your usual self and you felt so good or so hyper that other people thought you were not your normal self? You were so irritable. You felt much more self-confident. You had a higher libido. You had racing thoughts through your brain. I mean, there is many things that lists here. And then it says, if you answered yes to more than one of the above, have several of these or of these happen to you, more than one of these ever happened to you at one time. And then it says, how much of a problem are these causing you? Have any of your blood relatives had manic depressive illness or bipolar illness, and has a healthcare professional ever told you that you had a manic depressive disorder or a bipolar disorder? Now that's just an example of one mood disorder questionnaire, but it varies with each patient. I mean, it's a good guessing game with all mental illnesses on how to pinpoint exactly. Until you rule all of them out, you can't necessarily say, hey, so it varies patient to patient. Signs and symptoms: when they're in a depressive episode, they have feelings of hopelessness, sadness, worthlessness, guilt. They've got trouble sleeping, which could be too much sleeping or too little sleeping. They've got loss of enjoyment of activities that they would typically enjoy. So like, I typically enjoy going to hang out with my friends. If I suddenly did not enjoy doing that anymore, that would be an indicator of something's wrong. Appetite and weight changes. Again, this can be weight gain or weight loss. Concentration difficulties and suicidal ideation. Suicidal ideation ranges like any suicidal thoughts or behaviors, or homicidal thoughts or behaviors. And then a manic episode, they are on this high of all highs called a euphoria. They feel on top of the world. Nothing can stop them. But yeah, they can be very irritable and angry, and something can send them over the edge just like that. They've got increasing activity. They've got more energy. They speak more, and their speech is quicker than usual. They are fleeting and impulsive. So if something that a normal human being would think was crazy, like spending $900 to go eat dinner, that might be completely normal to a person in a manic episode. They just don't see those normals. Or fleeting, like, fleeting impulsive, like, oh, it sounds like a great trip to go to Colorado tonight. I'll be back in a week, and just tell work tomorrow. So again, decreased sleep and appetite. They also have concentration difficulties when in a manic episode, and they've got that increased self-esteem and delusions and hallucinations. The delusional Delusional mania is a rapid onset of delirium. So they are completely out of it. And that happens with those in bipolar, with type 1 bipolar. Those are in those complete psychosis states. To be classified as a manic episode, you have to have 3 or more of the following, lasting for at least 7 days, so lasting a full week. Inflated self-esteem, decreased need for sleep, more talkative than usual, flight of ideas racing at once, distractibility, increase in goal-directed activity, excess involvement in activities with chances of painful consequences. So if you've got 3 or more of those that last at least a week, that is considered a manic episode. A hypomanic episode is 3 or more of the following, lasting 4 days, at least 4 days. Again, inflated self-esteem, decreased need for sleep, more talkative than usual, flight of ideas racing through your head, distractibility, increase in goal-directed activity, excessive involvement in activities with a chance of painful consequences, but these are not as severe as the manic episode. So they're just not as drastic. And then for the depressive episode, you need to have 5 or more of the following in a 2-week, 14-day period. Feelings of sad, hopelessness, worthlessness, guilty, less interest in pleasurable things that you would typically enjoy, significant weight loss or weight gain when you're not dieting or trying to, too much sleeping or too little sleeping, psychomotor agitation or retardation. So you are like on hyper alert to everything around you, or you just are like see nothing around you kind of thing. Fatigue and loss of energy, and concentration difficulties along with indecisiveness. They struggle to make decisions. And then again, suicidal ideation. Basic level interventions to care for a patient with bipolar disorder. You need to plan accordingly. Go in, be short and concise, set limits, set boundaries. This is what I expect from you. This is what I want to know what you expect from me. So you set those limits right off the bat. If they present any behavior that's not tolerated, we just kind of redirect them. Always actively listen to the patient, but yet remain neutral. Don't put your personal opinion into it. Always approach with a firm yet calm approach, and be consistent with the patient. Be consistent. With your advanced level interventions, you've got safety, which is your biggest one. So low stimulation, structured non-competitive activities to keep them busy, but we don't want to, be playing dodgeball or anything. Redirection of agitation. So if they are agitated or presenting unwanted behavior, then we just need to redirect them to, hey, would you like to go play a game of chess or something? And then medication, it's important to keep them on their strict medication regimen. Yet observe for toxicity. Protect your patient by not allowing them to give their money and things away, their personal belongings away. They may not understand that that's what they're actually doing sometimes, and then do not allow any sexual acting out. Along with that is hygiene, and you need to minimize your wild clothing. Like, just don't be extreme or super unmatched, or sexual items. That's where I'm going with this. No provocative, nothing super deep cut, nothing super short. And sometimes you, especially in those depressive episodes, you may need to give a step-by-step instruction on hygiene. Okay, shave your left, now shave your right, now put your deodorant on, now comb your hair, And then for nutrition, you want to watch their eyes and nose very closely and provide high-calorie protein shakes and finger foods, because a lot of times they're not going to want to sit and eat a meal. They may not think that we're watching, but we're watching when they go in and just grab that little bag of chips or just drink that shake. And it's also a good reminder to patients to frequently eat. It's also good to remind them to frequently rest and provide low stimulation during rest times. You know, dim the lights, no TVs blaring, no stereos. Let's shut the blinds. And then at nighttime, let's create those rituals and the routine every night of a warm bath or some music. Bless me, excuse me. A warm bath, some music, meditation, yoga, you know, whatever, a hot cup of tea, whatever helps that patient relax, let's do that nightly. And then if we can't achieve uninterrupted sleep, we can then try medication. And then last, we need to watch our elimination and make sure we don't need to be offering any other fluids or fiber, and make sure they're not constipated and they don't need like a laxative or something. So for manic episodes for mania, this was a good reminder to me on the symptoms of it. So dig fast, distractive, impulsive, grandiosity, flight of ideas running through your head, activity is increased, you're sleeping less, and you're more talkative. So then there's phases of mania. In the acute phase of mania is really the phase of safety, maintaining your safety. So you want to decrease any excess activity. You know, don't cut them off from the world, but we don't want 15, 20 people in the room. We don't want to be running 24/7. You want to present a healthy diet and to maintain a good diet and ensure a great 4 to 6 hours of uninterrupted sleep at night. Again, this is where you would assess elimination issues if they needed to focus on anything there and to meet self-care needs. And then this is where you also focus and figure out a great medication regimen for this patient, like patient specific. And then phases 2 and 3 are pretty similar, so they're tied in together in a lot. And this is where you learn to adhere and follow to your medication regimen, where you learn your communication skills and practice those stress reduction skills, and you improve your cognitive thinking. You've got, this is the time where they typically face any like legal or employment or marital issues. This is where they start to face it and accept that they have bipolar disorder. This is also where you need to address and make sure that each person has a great support system, offer support groups. There's Facebook pages, there's support groups you can attend, there's online ones, family, friends, whoever it may be for that person. With each therapeutic communication, enhances the safety of patients. So that involves active listening, but silence is not a bad thing. You focus particularly on the patient and what the patient is talking about, paraphrase things after the patient has stated them, restate and reflect, think about it with the patient, acknowledge that you understand, and summarize statements. If you don't understand something, say, I'm not understanding. Could you please explain it to me differently? Be calm, matter of fact, consistent, and concise. Avoid power roles. So do not engage in any negative manipulation that a patient may pull. Listen to and act when needed. Actually listen to your patients. They're telling you. If you feel if your gut is telling you something's wrong, something's probably wrong. Act on it. And then last but not least, encourage non-manipulative behavior. Settings for care may be the home. Many people live with this disease. Many people live with this disease and probably don't even know that they have this. So there's many people at home. You may be in the hospital, which may be your safest place, or if the hospital is still not necessarily the safest place for you. They may suggest seclusion, which you have to have a doctor's orders for. To restrain anybody, to seclude anybody, you have to have the doctor's order. But if there is a substantial risk for the patient harming themselves or others, the doctor is going to prescribe that. Again, if the patient is unable to control any like physical actions and the problem is escalating to a violent situation, that's going to be a substantial risk to others and the patient. So if less restrictive measures have failed, you may see seclusion. And our medication regimen, the biggest thing would be your mood stabilization. That is your biggest one, and that's lithium. I'll talk about that on the next slide. But your anticonvulsants like valproic acid, that's got the therapeutic level of 85 to 125, is your first line treatment for manic and mixed episodes. It cannot be used during pregnancy, but it is okay to use with lithium. And if you were to be toxic taking valproic acid, you may experience things like hallucinations, coma, confusion, or dizziness. Carbamazepine has a therapeutic level of 4 to 12, and it is a manic episode treatment. It does give you an increased risk for birth defects, so it's not necessarily suggested for pregnancy either. You're likely to see weight gain or even blood disorders, skin rashes, Stevens-Johnson syndrome, hyponatremia, or jaundice with carbamazepine. And then signs of toxicity would include nystagmus, where your pupils just sit and they shake and they quiver back and forth. And then involuntary muscle movements, seizures, tachycardia, and respiratory distress. And then we've got lamotrigine, and that is for bipolar depression long-term medication. Like, it's for maintenance of the long-term. And it is not suggested with valproic acid, but it is the preferred pregnancy method for depression, bipolar depression, but it also still has a very high risk of birth defects. So that's a good thing to know. It can cause weight gain, Stevens-Johnson syndrome, and aseptic meningitis. For our anxiolytics, we've got clonazepam and lorazepam, and those are for acute mania. That helps to slow down and manage our psychomotor agitation. Side note, SSRIs should be used with extreme caution because they can cause manic episodes. Your second generation antipsychotics, for mania, there's olanzapine, aripiprazole, risperidone, and acenapine. And then for depression, there's olanzapine, but a fluoxetine combination. And then there's quetiapine monotherapy and lorazepam for acute episodes. Lithium, the adverse effects are it does take 3 to 6 weeks to take effect. So if a patient comes to you in 2 weeks, says this isn't working, explain to them, well, it's because we need to give it 3 or 4 more weeks to take effect. It has a very small therapeutic range, and you have to have frequent serum level monitoring. Each serum level monitoring has to be taken like 10 to 12 hours after the last dose. Signs of lithium toxicity would be nausea, vomiting, diarrhea, vision changes, tremors, confusion, EEG changes, so changes in your heart rhythm, large output, seizures, and serum lithium level over 1.5 is considered toxic. With malotherapy, we need to create a safe environment, monitor for suicidal ideation frequently, follow all of our restraint protocols per facility and per physician. Decrease stimulation without isolating the patient. Again, so not 15 visitors, maybe decrease it to 1 or 2 at a time. Implement frequent rest periods, provide physical outlets. So let them go outside and walk, get out on the patio, they can still go do things. Protect from impulsive behavior and poor judgment. So don't let them give their items away or their money away. Sometimes they just don't even realize what they're doing. Remove dangerous items from the room if necessary. And then there's electroconvulsive therapy, also known as ECT, and this is used for severe symptoms that are not being treated or not resolved by anything else. So treatment's not working. It is indications for use would be rapid control of systems, catatonic symptoms, severe suicidal ideation, or severe symptoms during pregnancy. So here's another pregnancy option. Here's a quote I really liked. This is, if we can change what we are thinking and or change what we are doing, we can change what we are feeling. So cognitive behavioral therapy is where we really recognize, challenge, and change the patients. So this is really where they accept their diagnosis, they monitor their mood, they correct their flawed thoughts by becoming aware of their thinking, their surroundings, why they do the things that they do. They learn to problem solve and enhance their social skills, and then they stabilize this routine of living with this disease. Doing these things helps reduce the amount of symptoms and the rate of what you may relapse. Some stigmas that people have against people with bipolar disorder, they're dangerous, or they're just mood swings, or they're hormonal. I would say mood swings and hormonal are probably the two biggest, especially hormonal. 40 years ago, you know, people, oh, she's just PMSing, you know, she's just, it's her time of the month. No, this is an actual chemical imbalance. These aren't just mood swings. Like, they're mood swings, yes, but they're happening for a reason. And then abrupt changes in mood. A lot of times it's portrayed in movies that it is this abrupt, like, I'm fine, to absolutely. A lot of times there's indications of I'm going into a manic phase or I'm starting a depressive phase. It doesn't always happen in this instant of shock, you know? So strategies to address my stigmas, I think awareness and advocacy are really probably the two biggest, and listening. You got to listen to your patients to be able to advocate for your patients. But then awareness. I think a lot of people just don't even realize the struggles that we're having as a country with our mental health world. Like, people don't even know how big of an issue it actually is. There are so many people living undiagnosed, you know, or not even thinking that it's an actual illness, more so as just in your head, where there's actual evidence saying these are illnesses. So if we can just bring awareness and, you know, like normalize mental illness, it's okay. People can still live with this. Advocate for your patients. Like, your life is not over. You can still. So I think those would be my biggest strategies, would be bringing awareness to mental health as a community. Summary. Often it's unrecognized. There are many people living with it that have never been diagnosed. Yes, it is crucial to consistently set limits, even in the healthy phases of bipolar. Like, in the phases that you feel your greatest, it's great to still have those limits and boundaries. It's great to always have that family or support groups. Again, even in the good, always great to have those resources to fall on. And it is detrimental to follow your medication regimen diligently. That is crucial. Here's my references.